I work as a pharmacist at the Immunodeficiency Clinic at Toronto General Hospital. So it's a multidisciplinary clinic. There's pharmacists, doctors, social workers, and a research team, and nurses. So my role there is, like Kenneth said, to give people their medication, educate people on their medication, but not just their HIV medication. Any questions they have about anything that they're seeking treatment for, so blood pressure or diabetes or whatever it is. We all sort of work together and help each other troubleshoot our problems. So what we're gonna talk about today, it's hard to cover so much in such a short time, but we'll try to cover how HIV is treated, side effects of HIV, how they're managed, a little bit on prevention and what's in the future for treatment and what's in the future for prevention. So it's going to be very general, not delving into too much detail on any of those things, but of course if you have questions, we'll try to get to those the best we can. So this slide is basically representing all the developments that have happened over the years in HIV medication, starting from the mid-80s up until now. And as you can see, there's been a lot of progression. Things really picked up in the mid-90s. With the advent of a class of drugs called protease inhibitors. And just recently we've had a couple of new drugs that have come out on the market called elbitagravir and dolutegravir. So they're in combination products that you may have heard of, like Complera, for example. Those are newer things, and there's many more to come. So there's well over 20 drugs that are currently in use to treat HIV and growing. So every year there's a lot of development, like I said. And those 20 drugs come from different families of drugs. And those different families of drugs are used together to help stop the HIV virus from growing. So typically, you're treated on 3 different drugs at least from at least 2 different families. And how your doctor decides what drugs are best for you is something we'll talk about later. So when you start on HIV treatment, there's certain goals that your healthcare team has in mind. So they want to get your HIV under control. So they want to make sure that your viral load is undetectable, which means it's under 40 copies. They want to make sure your CD4 count, which is a measure of how well your immune system is working, is at a certain level. But in addition to that, they also want to improve your quality of life. So having your numbers where they should be isn't always good enough. They want to make sure you have a good quality of life. So mortality talks about, how long you might live, but morbidity refers to, kind of the quality of your life, the health of your life while you're around. So we really want to make sure that's the best for you. And the reason why that's so important, the quality of life is so important, is because there's a lot of complications of HIV and HIV therapy, as you can see. A lot of things are going on at the same time. So it's not just about getting your virus under control anymore. Now there's so many options, and technology is really advanced. So we really try to look at everything and try to improve your life as a whole. Improvement of your quality of life means that your healthcare provider has to make decisions about more than your HIV. As you saw in the previous slide, sometimes HIV drugs themselves can affect certain issues in your body, like your blood sugar or your cholesterol. So that's why it's really important that even if you feel like your HIV is under control, that you keep up with your appointments, because when you go to your appointments, they measure many things in your blood work. So they're going to keep on top of your blood sugars to measure your chances of diabetes. They're going to keep on top of measuring your cholesterol, see how your liver is working, see how your kidney is working. All of this needs to be monitored to, again, improve the quality of your life. And based on those things, sometimes is why your doctor may decide to change your medication or adjust your medication or add another medication. Again, it's not always about your virus alone. So some side effects are more associated to certain types of medications, and not everyone experiences the same thing. So if one person's on Kaletra and another person's on Kaletra, one person may have diarrhea and the other person may not. So it's never always the same thing. And the important thing to really remember is that when you have side effects, most of the time they can be managed. So staying in communication with your healthcare team is really important, because if we don't know, then we can't manage them. And you do see that a lot. Sometimes people are experiencing things that they don't need to experience. So it's really important that you let us know. So some common things are, nausea and vomiting, diarrhea. Jaundice is something that means your liver is being affected a bit. You might notice your skin is more yellow. Rash, and sometimes things in your central nervous system that make you sleepy or drowsy. So side effects such as nausea and diarrhea and headache, those are very common things, should happen less within a few days to weeks when you start on HIV treatment or when you've started a new HIV treatment. Generally, again, they can be managed through diet, through over-the-counter medications, through lifestyle things that you can do. For example, if you're nauseous, sometimes we'll ask patients, well, are you taking your medications with food? Are you staying upright after you take your medications for an hour? Those kind of things. And those kind of things can actually make a big difference. So it's usually, if after trying a lot of different attempts on managing your side effect, if it's still persisting, that's when we're going to try to maybe try an alternative, try something different. But it's always good to keep in mind that patience is important. Sometimes it can take a few weeks to feel normal. So more serious side effects are things that maybe we won't wait about, and that you need to let your doctor know immediately. So again, if your side effects persist or get worse, if you notice you have a rash or itch, that's something you need to let us know. If you notice your skin looks more yellow, the whites of your eyes are more yellow, and of course if you have any breathing problems or you notice any sort of change in your heart rate. And essentially, basically, if you can't continue the things that you normally do. So if you feel that, I can't take my kids to work, kids to school properly, or I can't drive, or, I can't work, things like that are things that you need to let your doctor know. So when you let us know about those things, we usually go through a series of questions to try to find a solution. So we try to see, the correct usage of your medications, other medications you're on, over-the-counter medications you might be taking. We might add or subtract something to manage a side effect, changing your lifestyle, or maybe changing your HIV regimen. It gets us to the topic of personalized therapy. So a question we'll often hear sometimes is, my friend takes 1 pill a day, why do I have to take 6 pills a day? And the answer to that is that everybody's different. So it's never a one-size-fits-all scenario. Your treatment regimen is individualized, and the options take many things into account. So again, we talked about not everyone experiences the same side effects. So what adverse or side effects are you experiencing? What are the drug costs or coverage that you have? Most HIV medications are covered in Ontario, but there are some products that are not covered through the government. Sometimes a lot of patients have private plans that don't cover sometimes newer products, basically. So sometimes that needs to be taken into account. Sometimes you have pre-existing issues that you're taking medications for. Maybe you're taking blood pressure medication or thyroid medication. So you can't take the same drug that someone else takes because it interacts. And something we'll get into a little bit more, maybe you have some pre-existing antiretroviral resistance. So your body basically doesn't react the same way or accept a drug the same way as somebody else's. And again, then your schedule or lifestyle. So for example, maybe you're somebody that does shift work and you start your shift work at 11 at night. Products that are known to cause a lot of drowsiness, for example, something like Atripla, maybe that wouldn't be the best choice for you. Maybe you work for an airline and you're flying all over the world. Maybe we need to do our best to find a medication that's once a day instead of twice a day or 3 times a day when you're in all these different time zones and this and that. So all these kind of things are taken into account. So again, a common misconception is that everyone has the same virus. And in fact, the strain of your virus might be very different from somebody else's. So the way they're going to get more information on that is through testing, resistance testing, or what it's called as genotyping. So it's a test that examines the actual structure or genotype of HIV that has been taken from a patient. So the HIV is examined for the presence of specific mutations that are known to cause resistance to certain drugs. So this is kind of just an illustration. So how many of you can think about a time where you've made a photocopy? Everyone's here has probably made a photocopy before. So suppose you put a piece of paper in a photocopier machine and you press make 50 copies. When you look at all those copies, do all the copies look exactly the same? No, right? Usually some copy is a little darker, maybe there's a little line through one of them, some of them are lighter. They don't look the same. So when HIV has the ability to keep copying itself, it's the same concept. Sometimes some of them look different. So those copies that are a little different are mutations. So taking drugs basically stops the ability for your drug to make copies of itself, and taking your drugs correctly, rather. Stops the ability of your virus to make copies of itself, and therefore stops its ability to create mutations. So when you have a lot of mutations, what happens is when you have a lot of mutations, your virus becomes resistant to a drug. It doesn't work the same way because there's too many variations of the copies for the drug to properly work. Okay? That's why taking your doses every day is really important, and taking them as they're prescribed is very important. When you start regularly missing your doses is when you start running into this problem. So there's a little bit of debate about it, but a lot of people believe that you do need to take your HIV medication correctly 90 to 95% of the time. Some people think it's lower, but in order for this issue to not happen. If you do stop taking your medication and your HIV starts mutating and resistance develops, basically your doctor has to start adding on more medications to your regimen. And sometimes you can become resistant to a whole family of HIV medications. We talked about how there's different families at the beginning, and sometimes an entire family won't work for you. So what happens is you're in this cycle of needing more medications, and yet less and less things are working and less options are available to you. So when you're entering into therapy, you're really at a time where you have usually quite a few options. So that way, if you have side effects or something isn't agreeing with you, then there's a lot of different options for what else they can pick. So again, just to recap, resistance, not everyone's virus is the same, and people's mutations can be different. So a drug that works perfectly for your friend may not work at all for you because the virus is resistant to that particular drug. Okay? So your doctor will conduct a test to find the drug that works best for you. Some newer products that not everybody is aware of. Last year we had a new integrase inhibitor called elbitagravir, which is a part of a new product called Stribild, or the Quad as people are referring to it. It's the first 4-drug combination that's being used in HIV. So it's 4 drugs in 1 pill, which is really exciting, I guess, for people, because it's always better to swallow less. So, and then another integrase inhibitor as well called dolutegravir, which will probably, I don't know if who's heard of Icentress? Yeah. So it's kind of more of a comparator to Icentress in that the difference is that it would only need to be taken once a day versus twice a day. So that actually I think I put pending approval, but while I was away it got approved. So the next thing we're going to talk about a little bit is what's down the road. These are some products that are in the pipeline. I'm sure you've heard of tenofovir or Viriad or Truvada, are those names that are familiar to you? So tenofovir is the chemical name of Viriad, and it's a part of Truvada as well. And there's a form of tenofovir, a new form of tenofovir called TAF, tenofovir alphenamide fumarate, that's being developed. So basically it's a more potent form of tenofovir, and they feel that it distributes throughout the body more than the old tenofovir. So that's something new. Funny little names here you see under that other NNRTI family of drugs are basically the numbers or letters that they use to refer to a drug before it hits the market and before it's available. Globally, it's referred to as TMC 278. So that's why these ones don't really have full names yet. So they're in early phases of trials right now. So the TMC 278 rilpivirine, which is a component of a drug called Complera, which is something you swallow. They're working on a long-acting injection. And dolutegravir here as well, they're looking at a weekly injection. So can we think of a reason why a long-acting injection versus taking a pill every day would be?
Adherence.
Right, yeah. So if they could create something that you would have to just poke yourself once a month, maybe there's less chance of you missing your pills. So those are things that they're looking at. So next up, we're going to talk a little bit about HIV prevention, and again, continue with the pipeline. What's new? So, forgive me. To understand the basics of prevention, we'd have to understand the basics of transmission. When I talked to Kenneth, he said that this was something you guys were pretty much more comfortable with generally. So I'll skim through it. You know, I won't spend too much time. So HIV infection can happen when exposed to body fluids with a high amount of virus. So that's an important point, a high amount of virus. If you take your medications regularly and your virus is undetectable, there's a lot less of a chance for you to transmit the HIV virus. That doesn't mean that you shouldn't practice safe sex and all those things we hear about, because of course there's STDs and other issues to always think about. So infectious bodily fluids include, I don't know why blood was on the bottom there, sorry about that. So those are a few of them: blood, semen, vaginal fluid, rectal fluid, and breast milk. There's other fluids there that, unless you're in surgery or something, probably wouldn't come across. So non-infectious bodily fluids, your feces, your nasal secretions, saliva, sweat, tears, unless of course they're visibly contaminated by blood. So condoms are the #1, message that we always send out for HIV prevention. As you can see, the World Health Organization's position statement on the use of condoms is the single most efficient available technology to reduce sexual transmission of HIV and other sexual transmitted infections. Okay? So consistent use can reduce HIV transmission by 80%, some believe more. Other forms of prevention, when we start talking about harm reduction, using clean needles, sterilizing any drug use equipment, including any straws, cookers, boilers, anything like that. And I think the take-home message with any sort of drug paraphernalia is not to share it. And of course, public health interventions are very important in the fight to prevent HIV. So education sessions, brochures, campaigns, fact sheets, educating yourself as much as you can, and promoting testing. The more people that know their status, the safer and healthier you can be from a public health perspective. So the risk is not knowing. So we're going to talk a little bit more about the future in terms of the concepts of prevention. So probably on the news you've heard a lot about HIV vaccines. And there's a lot of conflicting stuff. There's a lot of exciting things in this area. Currently, there is no effective HIV vaccine on the market. However, there are over 30 or 40 clinical trials of vaccines going on throughout the world. And there's been a handful of them that have shown a lot of promise. So, we don't know how far away we could be. some of the things scientists hope they can do with vaccines are what we're going to talk about. There's preventative vaccines. So that would be a vaccine that can help prevent HIV negative people from contracting the virus. So it's like the flu vaccine. You don't have the flu, it prevents you from getting the flu, or prevents your chances of getting the flu. Therapeutic vaccines would allow those with HIV to perhaps take less drugs, or perhaps no drugs, to help control their virus, and hopefully help make their immune system stronger. So those are two different types of vaccines that they're hoping to develop. So vaccine development is really exciting, and it makes for great news stories, but unfortunately right now we don't know when it could happen. It could take many years, maybe decades, we don't know, but there is a lot of strong promise. So a lot of other news this summer was about babies and bone marrow transplant patients and cures of HIV. So these are exciting areas too. They're areas of a lot of question and exploration. However, there aren't really definitive answers found right now. So the bone marrow transplant patients were people whose donors had rare genetic mutations that caused the people to be resistant to HIV virus. So what they can do with that after would be, is very complicated. But, they're probably going to look into, what they can do about those specific mutations that those people had, and, what they can find from there. There was also a baby that was born in the States whose mother had HIV. So they assumed the baby had HIV, but it was cured because they started the mother on HIV therapy. But that's also debatable because they don't know 110% if the baby was indeed infected with HIV first. And there was another French study in which a few patients were cured, but it's actually called a functional cure, which means they started their HIV therapy in the acute phase, so right away, which they don't usually do, for 3 years. Then they were stopped off their HIV therapy, and their virus is not growing. So it's been a number of years now that their HIV virus hasn't been growing, and they're not taking any medication. However, it still trace detectable, basically. And we don't really know how long it could last. So that's something that they call a functional cure. So these are all areas of exploration in terms of therapy and treatment, but we don't really have a lot of answers. So topical microbicides, so those are things that are like gels or films, suppositories, or even vaginal rings that can kill or neutralize viruses and bacteria. So right now, researchers are studying both vaginal and rectal microbicides to see if they can prevent transmission of HIV. A safe and effective and affordable microbicide against HIV could help prevent many new infections. Unfortunately, right now, they haven't found a microbicide that has had enough benefit. They don't know all the reasons for this. It could be poor adherence. It could be that it just didn't penetrate enough in terms of drug levels to be high enough to block HIV transmission. But currently they're actually studying some vaginal rings that contain more than one HIV medication in it. So we'll see what happens there. So as we talked about earlier, it's really important to educate yourself these are 3 really common websites that people use for information, but of course there's many, many more. But you know, I encourage you to always keep on top and of the information. There's always new things coming out, and contact your health professionals and ask them questions, because that's what we're here for. Certain medications like amphetamines or drugs like ecstasy or MDMA, things like that, that people, club drugs or things like that, that people take, that drugs, HIV drugs such as ritonavir, like you said, sometimes can actually boost the absorption or effect that you feel from those drugs by sometimes up to 50%. So yes, that is true. So again, usually when you see your doctor or pharmacist, we do try to ask, you know, are these things, you know, things that you take recreationally? It's important to let us know about recreational drug use, just from a safety perspective, right? So we can talk to you about how to take it safely.